So let's get started. So when you talk of body composition analysis, it has been there for a very long time in clinical practice. This is a very old paper published in 2002, but really dwells into how body composition can be deciphered in terms of looking at it at the atomic level, at the molecular level, at the cellular level, and at the tissue system level. But for simplicity, over the years, body composition has been studied in a very simple way, what was said to be the two-compartment model. As physicians, all of us are interested to know about the fat, and what we would say everything else which is not fat as fat-free mass. So it makes body composition look really simple. There's fat, and everything else which is not fat is fat-free mass. But over the years, with the sophistication of imaging, with newer types of body composition that we have today, we get replies in a body composition report like the protein content, the mineral content of the body, the water content, the skeletal mass content. And when patients come back with these reports to the clinic, they will ask the doctor, why is my mineral content low? Why is my muscle mass high or low? And how do I change it? And therefore, it is important for us as physicians to know little more than just fat mass and fat-free mass. To try and understand or dissect the body composition into different domains, let's go through this infographic. So if you have the whole body, as I said, easiest way is to divide the body as fat mass and fat-free mass. But the fat-free mass itself has a lot of components. The fat-free mass can be made into bone and the lean mass, because the bone is something which is very hard, very different from the soft tissue. So it can be either bone or lean soft tissue mass. Lean soft tissue mass is also not just one homogeneous aspect. It includes organs, includes water content, and skeletal muscle content. When you look at skeletal muscle content, that is also not uniform, and skeletal muscle content can also be further classified or categorized as skeletal muscle, which is present in the appendicular mass or in the non-appendicular mass. Apart from that, is fat mass uniform? Again, I'm sure all of us have learned in physiology, fat mass is also not uniform. We have the subcutaneous fat and the visceral fat, and the visceral fat is the one which is bad. So to simplify, if we look at a body composition, we can divide it into different aspects. But as clinicians, if I have to pick up just two aspects in this body composition, that is the visceral fat assessment and the skeletal mass assessment. So I'll mainly focus on the fat. Dr. Sahana, who will speak after me, will focus on the muscle mass assessment. But in general, when we split body composition, this is how we do it. And this paper that we had written just recently got actually published yesterday in JAPI. So whatever I'm going to present, including the cases, are in that manuscript, which should be in print in JAPI in a couple of weeks from now. But before I go on to the cases, I'll take you through how to interpret a body composition report that you get out of a DEXA scan. And if you look at the body composition report, I would broadly divide it into 5 different parts. They have the demographic details on the top. It has details on body mass index, about body fat, muscle mass, and regional fat parameters, and I'll dwell with each one of them individually. Let's first start with the demographic details. Now it looks simple. It will have the name, age, gender of the patient. But as a clinician, if I have to look at one important thing in terms of the demographics that is mentioned on the report, that is the age of the patient. I should make sure that the actual age of the patient is mentioned here. It's not the Aadhaar card age, it's not the empirical age that the patient is given, or not the hospital record age, because later on when we see the different parameters and percentiles that are calculated, they are calculated by the age which is entered here. If this age is wrong, if this age is entered as 60 years, whereas my patient is 70 years, it will show grossly lower values. So whenever you get a body composition report, the first thing that you have to do, make sure that the age of the patient is mentioned correctly. If not, don't interpret, ask the technician to change the age and recalculate the percentiles. The second important thing, as you see, is the anthropometry here, that is the height and the weight. What I must mention here is This height and weight is not the one which is calculated by the machine. This is the one which is entered by the technician. So if my technician is not entering it properly, it will show a false report. What is captured by the machine is also going to be shown later on, and then you can tally whether your machine in the scan room is correct or not. So that's about the demographic details. Next three things, the body mass index, the total body fat indices, and the muscle mass indices, we look at it together. So we look at the body mass index. This is how it appears. Again, what I must emphasize here, this body mass index is not, again, that is based on the machine calculated values. This is dependent on what my technician has entered in the report, in the demographic details. In body fat and muscle mass indices, if I was to pick up the most important things that we have to look out, there would be 5 important things. The total body fat percentage, fat by height square, visceral adipose tissue area, lean by height square, and appendicular lean by height square. Now again, we spoke about the 2-compartment model. I said in the body, everything is either fat and everything else is fat-free mass. So that is something that is replicated here. If I add up the fat by height square with lean by height square, I should get the BMI, right? Because I'm saying it's a 2-compartment model. So everything is either fat or lean mass. And if I add these two, I should approximately get to what the total BMI is. Now this is very helpful when you're reviewing papers or you're looking at data, because somebody is, just put data without actual numbers, it is fudged up data, because if the mean fat by height square in a manuscript and the mean lean by height square is not adding up to the mean BMI, I know the data is not correct. Right? So this is an indirect way of assessing whether your report is okay or not. We have the total body fat percentage here. In this particular case, BMI is 30, total body fat percentage is 50. Now what is total body fat percentage, what is normal total body fat percentage is very debatable. Different studies, different organizations talk about it differently. The American Association of Clinical Endocrinologists gives a value of 35% and 25% for women and men. The Asia Pacific region details are 33.4 and 20% for men. The Endocrine Society of India Clinical Practice Guidelines makes it simple. Anything above 25% is abnormal for men. Anything above 30% is abnormal for women. So that's about the total body fat percentage. So we've talked about 3 things so far: total body fat, fat by height square, and lean by height square. Let's talk about the visceral adipose tissue area. Now this is something which is estimated, not really directly calculated as it would have been in an MRI or a CT scan. What is normal value? We're looking at the last value here, which is the fat area. A normal value would be anything less than 100 centimeters square. This is a study from our center led by Sahana, looking at mother-daughter pairs, and we showed that if the VAT area is more than 100 centimeters square, the odds of developing a cardiometabolic problem is 2.2. So that's the threshold which is prescribed. VAT area normal would be less than 100, more would be more than 100 centimeters square. And the last thing is the appendicular lean by height square. Again, we'll learn more about it as Dr. Sahana will talk about. Again, this is one parameter which helps us diagnose sarcopenia. And for the Asian population, the cutoffs are less than 7 kilograms per meter square in men and less than 5.4 kilograms per meter square in women. And this is the definition for sarcopenia, one of the components. So this in brief are the 4 important aspects on a DEXA scan. The 5th aspect on a body composition is the regional fat parameters. This helps us understand how the fat distribution is there across different limbs and across the body. Now, just a couple of points before we look at the regional fat distribution. What we see here is a total mass. Now, this is actually the weight which has been calculated by the machine. I said on the demographic details, we have a weight which is entered by the technician. This is the weight which is calculated by the machine. So you can see whether it is matching or not, and whether your scan room machine is actually doing well or not. The total body fat percentage, how we calculate, we have the total fat mass in grams. divided by the total mass in grams. And if you do a percentage, it's 53%. This was the percentage that we had seen of the total body fat which was there. Now, when you talk of regional fat parameters, there are two columns here. One is mentioned as YN, the other is mentioned as AM. YN is when you compare this patient's fat percentage to a young, normal person, whereas AM is the fat percentage when you compare to an age-matched person. And that's why I said it's important to have the right age right in the front, because otherwise it will compare it to an age that you have entered, which may not be the actual age of the patient. So this is in brief talking about the 5 different parameters that we see on a DEXA report. Hereafter, I will just present a few cases, how this is clinically relevant for us in the clinical practice. These are all real-life patients that we've seen in the last couple of weeks. The first patient that I'm presenting is actually a patient who was referred by a rheumatologist. This is a 57-year-old gentleman. I clearly remember a very astute gentleman. He was an ambassador for the Indian government in several countries, very well educated, very eloquent person. He had rheumatoid arthritis, he has interstitial lung disease, he's on glucocorticoids, apparently lean, came for follow-up, and because he's got type 2 diabetes. And the reason he came to me was for a very simple reason, as Dr. Phoebe had presented. He really wanted to know, doctor, this dietitian of yours is asking me, to reduce my fat intake to so much, but I thought, my BMI is 19.6. I'm underweight. I thought I should have the flexibility of eating anything. I would love to have samosas, pakoras, anything in the evening for tea, but she's asking me to restrict my oil intake to 500 ml per head per month. Is that really something that you think is right when my BMI is 19.6? So to answer such questions, body composition is helpful. As you see, that the BMI is 19.1. But when we look at the body composition analysis, as I said, we look at 5 parameters here. The first thing is, if I add the fat by height square and lean by height square, I should approximately get the BMI, which I'm getting. Adding 5.8 with 13 gets me around 19. But despite having a very low BMI, look at his body fat percentage, 29.5%. By all the norms that I showed you by different guidelines, including the ASI guidelines, it is high. It is definitely higher than 20, higher than 25%. So this patient has this phenotype, which is normal weight obesity. Despite having a normal BMI, his body fat percentage is high. Also, his muscle mass is lower than what should be. So definitely, this patient would fit into this phenotype where people have normal BMI as per BMI, but will have a higher body fat, and that's what is normal weight obesity. Is this something which is common in clinical practice? The answer is yes. This is a cohort-based study that we follow in Kerala, and we found that 1/3 of the study population in this particular cohort has normal weight obesity. That is 2/3 of all the people who have normal BMI actually have high body fat percentage. Do they have problems with diabetes, hypertension, dyslipidemia? We see that people with normal weight obesity, those which are highlighted in red, their prevalence of diabetes, hypertension, and dyslipidemia is at par as compared to people who are actually obese, and significantly higher as compared to those who have normal body fat. There's another study from our center looking at the lean PCOS phenotype. Again, the same concept of normal weight obesity, something like what Dr. Phoebe presented. It's another study from our center looking at rural India and prevalence of diabetes in lean people. We found that 1 in 20 people from rural Vellore who are newly diagnosed to have diabetes actually have a BMI less than 18.5, and they still have high body fat. This is something which is endorsed by the Endocrine Society of India guidelines, by the RSSDI guidelines, and therefore this is a phenotype that you can only diagnose with the help of body composition. You cannot do this without that, because the BMI is normal. Let's move on to the other end of the extreme, and I'll take case 2 and 3 together. Case 2 and 3 coincidentally presented to the bariatric clinic that we have in Vellore on the same day. So these 2 patients, the first patient is a 37-year-old lady. She came to the bariatric clinic. In the bariatric clinic, for entry into the clinic, the BMI should be above 35. So they have morbid obesity. So this patient has a BMI of 41. Her A1C is 6.2%. got impaired fasting glucose, her blood pressure is normal, she's got borderline cholesterol levels, somebody's advised her lifestyle modification for that. Ultrasound is not showing any fatty liver. So 37-year-old lady with morbid obesity, pre-diabetes, borderline cholesterol, no fatty liver. Coincidentally, on the same day in the clinic, a similar aged lady, similar BMI, 43, A1C is 9%. She's already on metformin and lifestyle modification. She's already on 2 antihypertensive drugs. She got florid dyslipidemia, grade 2 fatty liver. So you see 2 women coming from the same locality. They're actually neighbors. They have very similar dietary recall, very similar physical activity. But despite that, despite having the same BMI, one patient seems to develop all the metabolic problems, while the other patient does not. Let's look at their body composition report. Now again, we looked at the fat by height square and lean by height square. They should add up to the BMI, which is happening in both these patients. One glance at the body fat percentage, again the normal, I would say, at least should be less than 30 in women. This is 44 and 40, so both have high body fat. But if you look at the visceral adipose tissue, the last line here, you see the lady who does not have metabolic problems, it is 62, whereas the lady who has the metabolic issues is 133. The threshold we said is 100. Any visceral fat area which is more than 100 is said to have high amount of visceral fat. So you see how body composition does explain the metabolic problems in one person despite the same BMI, whereas not so in that who does not have high visceral adipose tissue. This is something like that YY paradox, but that was at the lower end of the BMI. This we are talking at the higher end of the BMI. There are indirect ways of also assessing visceral fat. This is another paper that we had looked at, looking at simple algorithms, very similar in clinical practice when we estimate GFR. None of us measure GFR, we just estimate it with the help of a formula. Similarly, visceral fat can be assessed with the help of simple formulas, and this is one which we validated in our population. Let's move on to the fourth use of body composition, which is predominantly focused on regional fat estimation. This is a story of a 24-year-old girl presented with diabetes of 2 years duration, severe acanthosis, acromegaloid appearance. Any resident who will see her first time will ask for growth hormone and IGF-1. I remember Dr. Sahana had seen this patient. I think she tested twice for growth hormone and IGF-1 because she was so sure that this looks acromegaly, but she didn't. This is a clinical photograph. She's got umbilical hernia, she's got a large tongue, very acromegaloid appearance. One look at the body composition report, if we just focus on the regional fat parameters, we look at the distribution of fat in the appendicular region, you see it is just, everything is just 1 percentile. This is something which is complete lipodystrophy. This was a genetically proven case, but we have acquired lipodystrophy, which is more common in clinical practice, especially patients who are on heart therapy for HIV and some other drugs as well. This is a patient with a complete lipodystrophy. And again, this is something that you can easily diagnose with the help of body composition analysis. Very recently, we've also published one of the largest series in the world of different lipodystrophy related inherited congenital lipodystrophies. I move on to the last case, which is the fifth case, and this patient I saw yesterday in OPD. This is a patient who I've been seeing since 2015. And why I fondly remember this patient is this is the first patient I referred for bariatric surgery when the bariatric clinic was started. So, always your first patients for some things are very fond patients. Excuse me. So this is a story of a 40-year-old boy who underwent bariatric surgery in 2005 and has been concerned about not losing his weight despite good exercise. So this was his initial preoperative body composition. Obviously, he had severe obesity, BMI of 63, very, very severely obese. All the parameters are sky high, the total body fat, lean by height square, appendicular lean by height square. Post-operative, he had a sleeve gastrectomy. Obviously, the weight comes down. The BMI of 63 came down to 46. Down the line, 9 years follow-up, again BMI came 29. And he came to me last year saying, "Doctor, now my weight has started increasing." I've gained about 5 kgs in the last 1 year, so what should I do? I've had bariatric surgery. I'm very happy with the reports and everything that has happened, but now I've started gaining back weight. So I gave him the usual story that I tell for all patients with obesity on lifestyle. You have to eat on time, you have to reduce your carbs, you have to improve your protein intake, reduce the oil intake in the house, less eating outside, and whatever those 10 to 15 points that I would tell, and improve your physical activity. And he came to me this week, and he said, "Doctor, I followed everything that you said, and I have gained weight after that also. And my BMI from 29 has become 31. I said, "Well, let's do a body composition and see what's happening." And what we saw was that, his visceral adipose tissue, which was a year ago 122, which we know is bad, has become 84, significant reduction. And his muscle mass has actually increased. He's started going to the gym, doing resistance exercise, and muscle mass has increased. So this is another use of body composition where when the weight is increasing, but the healthy weight is increasing, the fat is actually coming down and the muscle mass is increasing. And this is again something that you can do only with the help of body composition. So I'll stop here. The key learning points from this 20-minute session is that yes, body composition does help us to understand the concept of normal weight obesity, rationalized treatment of the thin fat phenotype. It helps not only in thin people, but even in severely obese patients. As we saw, despite morbid obesity, the visceral fat component can be very different. We looked at the importance of knowing the visceral fat, the body fat distribution in terms of lipodystrophy that can be diagnosed. And last, also, sometimes when weight gain is there, it may be healthy weight gain, and that is also something that can be deciphered with the help of body composition. We'll stop here, but would be happy to take any questions. Thank you.
By some people, and how they match with the BMI machine.
Right, very important.
DEXA machine, yeah.
So there's a study done by Dr. Nitin, who was there in the audience. He's not there now. So there's a study from our center comparing DEXA and bioimpedance. Bioimpedance can give a fairly good value. Some of my PhD work in the community is through bioimpedance, but you have to have certain precautions. The patient has to be fasting. The patient's bladder should be empty. There are specific details about not smoking, abstaining from alcohol. So if all those measures are taken in place, then it is fine. Because otherwise, simple addition of water itself, drinking 1 liter of water and doing a body composition before and after, because it is based on the electric current that passes through the body and the time it takes, it can be very different. So if all the simple precautions that are mentioned for body composition analysis with bioimpedance are followed, you can get fairly good results. In the study that we did in Vellore comparing DEXA versus bioimpedance, we got fairly good correlation.
Thank you.
Good morning. I'm Dr. Vandana Jain from Delhi. So, very useful talk, sir. So, my question was that, like in children, when we describe body composition, we prefer to use fat mass index and lean mass index rather than fat mass percentage because we feel that it takes into account the skeletal size. Right. So, would you also recommend something similar in adults? Like you'd shown the guidelines which typically say that, okay, more than 25% fat is bad, but we typically don't use the indices in general practice, and why is that?
Right. So the normative values for indices are not so widely available, whereas for percentage, they are available. Fat indices are more accurate, I agree with you. Definitely very helpful when you're comparing within a patient. But when you're comparing intra-patients, the normative data is not there.
So because you had shown the percentile values, so there the percentile values were available. I was looking at your slides, and for example, the patient who moved from a lean mass index of lower to higher after bariatric surgery, so there his percentile also improved, but possibly they're not being used that much.
Correct. Then these percentiles are based on Western Caucasian database. Yeah. This is through hologic machine.
So we don't have Indian data for the percentiles. No.
There's one study by Dr. Raman Marva in Delhi, which has given normative data for the body composition analysis, but that's also with percentage only.
Okay, so one last question, that how's your experience with BotPod, and is it like comparable to DEXA?
not much experience on that.
Thank you.
Thank you.
Excellent talk, Dr. Nitin, as always. Two questions. So I'm a pediatric endocrine, Leena from Hyderabad. So what is your experience on doing body composition or assessing body composition in children and adolescents? Number one question. Second question is, when they come with the reports, like, do you want us to, because I do not have much experience or probably any experience in body composition in children. So do you want us to keep something in mind regarding the machines that are used, the different companies or something like that?
Thank you. Very good question. So my experience with children and adolescents, again, was through my PhD, where we're looking at the monogenic causes of obesity. And I've studied those children very carefully in terms of their body composition. I think the simple message is it's very hard to just interpret one report, but the same patient, if you follow up with the body composition, you are able to give very insightful meaning to the patient in terms of therapy. But just one cross-sectional report is very hard to interpret because it depends on the pubertal stage of the child, it depends on the stature of the child, the genetics. So I think on follow-up it is very helpful, but as a cross-section may not be. Regarding your question about the different companies, I think more than the companies, we have to look into the type of method for body composition, like DEXA is one and bioimpedance is one. It's very hard to compare both, but within them, they are fairly good.
Yeah, thank you.
Last question, I think. It was excellent talk, Dr. Nitin. I am from Nepal, Dr. Robin Maske. So I have questions. Is it possible to do this analysis in disease patient who have anasarca? So how do you interpret the patient with anasarca with this body fat analysis?
Fantastic question. So we've done body composition in people with CKD who have, anasarca. I think the bioimpedance is not reliable, but DEXA is reliable. It doesn't really matter with the water and the peripheral, because it's an imaging, whereas the bioimpedance does get affected grossly.
Thank you.
Thank you, sir, for that kind introduction. First of all, I'm very happy to be back in Vellore after so many years. A disclaimer here is, I think with respect to DEXA, I've mainly worked on bone density and visceral adipose tissue. Muscle mass I have worked on, but I have not published. So mostly what I'm going to present is a kind of a review of literature. So when we say body compositions, all these years, I think what we're mainly focusing was on obesity. I'm sure personally, we would also have probably just looked at our weight or waist circumference, but have we ever really thought of looking at our muscle? Do we really do that in our patients, for our patients in clinical practice? So the question I would like to start with, is there a need for assessing muscle mass? Is it only that patients with certain condition needs to be assessed, or there is a need in general? So when we ask these questions, most of us would think that, and also we would remember that some of the patients who are, some of the individuals who are in bodybuilding or such sports and competitions probably would come and ask us for this assessment. In general, probably we would not think of this, because generally, initially, it was only thought of more of a cosmetic or a bodybuilding aspect. And then we realized that when we talk about muscle health, it's not just the muscle mass, it's also the strength and the performance which we're talking about. And eventually now we know with this more and more understanding of muscle loss and sarcopenia, that this has a direct implication on our health. We talk about concept of healthy aging, and there is a significant link between cardiometabolic diseases and also frailty, osteoporosis, fracture, etc. when we talk about muscle mass. Thus, there is a significant need for understanding muscle mass and evaluate muscle mass. So, this is the outline. First and foremost, I'm going to talk about why it's important to assess the muscle mass. A little bit touch on sarcopenia, the assessment tools, and the DEXA muscle mass analysis. So we know that there is a significant changes in the body composition with age. We all lose some amount of muscle, and we also gain some amount of fat, most importantly the visceral obesity, which predisposes to metabolic diseases. Now on average, the lifespan, we see that the annual rate of muscle loss is around 0.4% or 0.3%, that is around 4% roughly per a decade. But with age, around 40 years, we start losing around 8%, and this increases to 50% loss of muscle loss per decade after 70 years of age. Now, this is how the life course of the muscle strength. If you look at the graph, we remember even a bone density, the bone accure also looks somewhat similar. Even the muscle accure also looks similar, where we attain a peak towards adulthood, maintain, and then around 30-40 years there is a decline. Now again you can see that there is a range. Now there could be significant individual variability in the muscle strength, and also the rate of decline of this muscle mass and muscle strength would vary across individual. So classically, whenever we discussed about muscle mass or sarcopenia, it was thought to be a physiological change with age, although that is to some extent true, but then we now know that this could be influenced by several risk factors, and it is no longer just a physiological state, but is now classified as a disease condition, and sarcopenia has been identified as a disease condition. So what do you mean by sarcopenia? Again, initially when sarcopenia was discussed, the definition was pertaining to muscle mass, but now we have a more conceptual framework where when we operational definition which says that sarcopenia refers to age-related decline in muscle mass, strength, and also the muscle performance. So all these three aspects are very, very important when we talk about muscle health. Now, why are we discussing this muscle health? Now, I spoke about sarcopenia and decline in the various aspects of muscle health. And then you could also have sarcopenic obesity, where you have excess adiposity, predominantly visceral obesity, along with sarcopenia, which is called a sarcopenic obesity. And there is a close association between the bone health and skeletal health, which are kind of interlinked. And also you can see that they have a shared risk factors. So we often come across this osteosarcopenia, and then you could have some patients who have all of these components, which can be called as osteosarcopenic obesity. Now, sarcopenia and sarcopenic obesity has been significantly linked with cardiometabolic diseases, diabetes, and also malignancy. And when it comes to osteopenia and sarcopenia, we know there is increased risk of frailty and fractures. What that means is an increased risk of morbidity and mortality, disabilities, and poor quality of life. So that leads to a significant impact, clinical and economic implications on public health. Now, we discussed that sarcopenia, although is an age-related process, there could be several risk factors which could accelerate this process. Now, what are the risk factors? One of the important lifestyle risk factors is the physical inactivity and sedentary lifestyle, which is kind of an occupational hazard in today's lifestyle. Obesity, any chronic diseases which leads to immobilizations, and then you have intrinsic risk factors like chronic inflammation, mitochondrial dysfunction. Again, this is coming up in a big way in many of the diseases. We know that mitochondrial dysfunction is an important risk factor. Hormonal distress, more importantly, age-related decline in sexual hormones and muscle degeneration. Now, that was about the clinical implication of muscle and why it's important to study muscle. Now, if I want to study muscle, what should I measure? It should be, is it the quantity, is it the quality, or it's the strength? And then, of course, by the definition, we know that all three are important, because individually each of these have shown significant link with cardiometabolic complications, frailty, and mortality. So, this is a kind of a broad review of how you approach sarcopenia. First and foremost, I know in a busy EPD it's very difficult to do all the tests. What we can do is just identifying the patients who are at risk. That we can do with a simple questionnaire called SARHIF questionnaire. And those who are identified to have high risk, then you subject these patients to the first test, that is assessing the muscle strength. And then who are found to have a low muscle strength, then you do the muscle mass analysis to confirm the presence of sarcopenia. Further, you could also look at the muscle performance to look at the severity of sarcopenia. Now, I'm not going to detail of this question. It's a simple questionnaire which can be used, where it looks at different parameters like strength, assistance in walking, rising from chair, climb, stir, and pass. And you have a Likert scales, which helps us in kind of identifying patients who are at risk of sarcopenia, which is a simple tool which can be used in OPD. And then once you have screened, then the first test you do is the muscle strength. Now, those who have a low muscle strength and muscle mass are diagnosed as sarcopenia, and then further severity is assessed by muscle performance. So, muscle strength assessment, again, it's very, very easy to do. All you need is a handheld dynamometer. So, you check the muscle strength with that, and you have a cutoffs for that. So, based on that, we can identify a patients who have a low muscle strength. Now, I've been looking at this in the practice. I have not published this, but then we were looking at this pattern. We saw that even younger patients could have low muscle strength. So, this is not just an age-related decline. This is pathological. Those who have limitations in doing this, they can go for isokinetic dynamometry using knee extensor. a strength. But the most practical would be the hand grip strength. Now coming to the topic of discussion, that is the muscle mass assessment. Now Dr. Nitin has covered most of it. To understand the muscle mass, we need to understand the body compartment. He's already discussed about the C1 compartment, the C1 compartment, C2 compartment, fat mass and fat-free mass. Broadly, when we say fat-free mass, they refer to lean body mass, but this also includes the bone. So 90% of the lean body mass would be lean soft tissues and 10% would be bone. Then specifically when we say lean mass, again around 53% would be the skeletal muscles, and this also includes connective tissue and internal organs. Now when you look at the muscle mass, again 75% of this is from the appendicular muscle mass, that is the muscle mass of the upper limb and lower limb. And then specifically again further breakdown, you would see that in the appendicular again 75% is from the leg muscle mass. So whenever we're looking at any of the tools assessing muscle mass, we basically look at these, and different tools may give different components. We're either looking at the lean mass, we're looking at the skeletal mass, appendicular mass or the leg mass. So many of the, if you look at the diagnostic cutoffs in the sarcopenia guidelines, specifically they mention appendicular lean mass as the most important tool. So appendicular lean mass is a lean mass of the upper limb and the lower limb. And if you, in total, when you look at the lean mass, that's the total lean body mass. Now, what are the methods you have for measuring mean loss? You have direct methods, of course, anthropometry, then you have DEXA, CT and MRI, which have been the gold standard, and skeletal muscle ultrasound. Indirect methods, we already discussed the bioimpedance analysis for body composition can also give some muscle measurements, and then the creatinine dilution methods, again, not routinely used in clinical practice. So anthropometry is something we can easily do in practice. The commonly used measurements are the thigh circumference, calf circumference and mid-arm circumference. We can understand that it's a crude measurement, but then it's helpful for follow up the patients, because here it's not just the muscle, you're looking at the whole girth, but then for follow up of the patients this is very helpful. Coming to the DEXA body compositions, again Dr. Nitin has clearly discussed on the body, how DEXA is a standard tool for body composition analysis. Again, this is based on the 3-compartment model because it gives us data about lean mass, fat mass and the bone mass. Now, again, when it comes to muscle mass analysis, DEXA is considered as a reference tool. Why so? We'll come to it later. Now, in DEXA, we can simultaneously measure lean mass, fat mass and bone mineral content. And the two important measurements we get is the total body lean mass and the appendicular lean mass. Now we know that there could be significant differences in the body size of the individuals. Thus, these measures are corrected either by BMI or for the height square to get the indices. So what the standard ones which is reported in the DEXA is the lean mass index and the appendicular lean mass index, which has lean mass corrected for the height square, and appendicular lean mass index is the appendicular lean mass which is corrected for the height, that is height squared. So this is what we get in the report, and this is how the DEXA reports looks. I think again this has already been explained. You get fat mass, lean plus BM total mass, and then the percentile of fat, and then you get various adipose indices. What we are interested in is in the lean indices. So you can see you get the lean mass index, that is lean by height square, and appendicular lean mass index, that is appendicular lean bar height square, which is the most important parameter. Now, why we are focusing on the appendicular skeletal mass is, like I already discussed, 70% of the total skeletal mass is actually appendicular lean mass, and also this is the one which is most active. And also when they have looked at clinical studies, this is the appendicular lean mass has a good correlation with the clinical complications associated with sarcopenia. So most of the guidelines which are looking at the definition of sarcopenia, they have used appendicular lean mass as the parameter to define the muscle mass, and then you have different cutoffs from different bodies based on the ethnicities they have studied. What we can probably concentrate is on the Asian working group of sarcopenia, where the appendicular lean mass cutoffs of around 7 for men and 5.4 for women is what the cutoff we can follow in our patients. So let's look at this patient's report. This is of 60-year-old lady who's got a body composition done, and I'm just looking at the lean indices. What you see is that when you look at the report, you get two things. One is you get the indices, that is lean height square and appendicular lean mass per height square. This I told the cutoff, so you can see this is above the cutoff. So operationally we don't define as low bone mass, and you also get percentiles, that is age matched percentile, which is around 50, and that is for a young normal, where you're comparing the bone, the muscle mass of the lady to the young normal, which is already there in the system, and then you have the age match control, and you can see the percentile is around 50. This is another lady of similar age. You can see, if you look at the lean indices, you can see that the appendicular lean mass index is less than the cutoff. So we can define as low muscle mass in this patient. And if you look at the percentile, it is 1 and 3, clearly suggesting that this patient has low lean mass. So over the years, DEXA has evolved as one of the standard technique for assessment of muscle mass. Again, this is an area which is slowly evolving, and the guidelines are just coming out. Now, DEXA was also kind of validated and looked across the previous gold standard techniques, that is the CT and MRI, and then they showed good correlation with the DEXA-derived lean mass, and in this particular study, the MRI-derived skeletal mass, and also with the CT-derived skeletal mass. So thus, again, talking about the utility of DEXA for assessing the muscle mass. So what are the advantages? It's accurate and reproducible. You already have such studies which have come up with validated cutoffs in different populations, non-invasive, minimal radiation exposure as compared to CT or MRI. I can say almost negligible radiation exposure, relatively cheap, rapid because you get all the components within one scan, and you get 3 compartment measurements, and low precision errors. However, limitations are you cannot look at a specific region, you get it the whole body or the appendix, not portable, so cannot be used for large scale epidemiological studies, and limited availability. There could be some influence of hydration, but again not as bad as the bioimpedance analysis. Let me quickly go through the other methods which are being used for muscle analysis. CT and MRI have been considered the gold standard because here you can directly compartmentalize and look at precisely evaluate the muscle in that particular region. Generally they look at the cross-sectional area at the level of L4, L5, and in MRI you not only get the cross-sectional area, but you can also look at the muscle quality. And most importantly, the intramuscular fat, IMF, is now being proposed as one of the important risk factor for cardiometabolic diseases, and this particular evaluation is very useful for that. It cannot be used as a screening tool in a clinical practice. It's mostly for research-based smaller studies to understand the muscle quality and quantity because of the limitations like the complicated procedure, the need for expertise, and also the cost. CT is again one of the first tool which was used for quantifying muscle mass. Again, you look at the cross-sectional area and then quantify the muscle mass. You can also look at the muscle quality parameters like intramuscular adipose tissue, muscle attenuation, etc. And of course, again you cannot use as a clinical tool for assisting sarcopenia because we know of the radiation exposure, cutoffs are not standardized, expensive, time consuming, and use standard is. Mostly it is used as an occupational opportunistic examination where you already have a CT of the patient done for some other purpose, like a tumor or trauma, and then you can quantify the muscles and prognosticate the patient. Peripheral QCT we know are being used more and more in the assessment of skeletal health. Now this can be utilized to assess the muscle mass. It's slowly upcoming as one of the tools for assessing muscle mass. And then ultrasound is also been repurposed to look at the muscle health. Generally it was used for kind of looking at local pathologies. Now this is being explored to understand the muscle mass because we know it's inexpensive, portable, easily available. And these again parameters are developing. Again it is not validated, but then this is something we can look forward in the future. Bioimpedance analysis has been used, again we already discussed that routinely it has been used by body composition analysis. You do get some estimation of muscle mass. It's not a direct measurement, it's just an estimation. So there are several limitations. But after DEXA, if you want to use any tool, you could use body impedance analysis. This is comparison of different tools, and you find that although CT-MRI are more accurate and reproducible, they have a lot of limitations in terms of cost, radiation exposure. So DEXA again fares better in this. Next comes the body impedance analysis, and then of course anthropometry. Before completing the talk, let me touch on the last aspect, that is assessing muscle performance also is an important parameter. Like I said, once you screen and then confirm the diagnosis by muscle mass, you look at the performance assessment. Very helpful in elderly patients because here it's not just the muscle, but it also requires neuromuscular coordination. Simple test which can be done is looking at the gait speed. We ask them to walk for 4 meters and look at the gait speed. 5 times chair stand test, and you have a different cutoffs for these tests. And again, you have several tests which can be done easily in routine practice, like chair stand test, asking the patient to just time up, get up and go around, and you time and see if the patient is able to do. Hand grip test, balance test, which put together can give a lot of information on the muscle health of the individual. Again, very helpful in elderly individuals. Now, There are several consensus which have come up from different guidelines on the sarcopenia diagnosis, and then again based on population cutoffs they are different. I think something close to us is the Asian Working Group for Sarcopenia. Even the revised European Working Group of Sarcopenia in older people also kind of gives a detailed evaluation of sarcopenia which we can refer. But important that we need to understand that it's not just the muscle mass, it's important to assess the muscle strength and the muscle function as well. So, so the take-home message is that I think we need to start looking at muscle mass analysis in our patients, at least start screening those at risk and then educate the patients in this direction. And when you're looking at muscle health, like I already said, assess strength, mass and the performance. There are several tools available, each has its own merit and demerits, but DEXA is the reference tool for assessment of the muscle mass, and assessing and addressing sarcopenia in at-risk population should be tried and incorporated in clinical practice. Thank you.
When we look at the densitometric definition of osteoporosis, so why the bone mineral density actually gained importance? This was, first when the WHO convened this panel, when osteoporosis was defined on the basis of bone mineral density in 1994. So this uses bone mineral density as measured by DEXA for defining the disease, and we know the cutoffs of normal osteopenia and osteoporosis to define osteoporosis. Now, the definition of pediatric osteoporosis or low bone mass is slightly different. So, a presence of a non-traumatic vertebral compression fracture without the need for BMD criteria, you can actually diagnose osteoporosis. But in the absence of a VF, the diagnosis in pediatrics requires both a clinically significant fracture history, that is more than 2 long bone fractures by age 10 years, or more than 3 long bone fractures by 19 years, and a low age and gender-matched BMD Z score of less than or equal to -2 with appropriate corrections for bone age. Now, we'll talk about this. But when you look at the principle, the broad principle of dual energy X-ray absorptiometry, now this is our brand new machine which we got just a year back. So you pass 2 X-rays with different energies, and then you subtract the bone tissue from the, you subtract the soft tissue from the bone, and then you get the bone mineral density. And how do you interpret it? Now we know that we have the Z score and the T score. Z score is when you compare person with a person of similar age group, but a T score is where you compare the bone mineral density of a person with a healthy young adult. So Z score should be used in men aged less than 50 years and all premenopausal women, and T score should be used in men aged more than 50 years and all postmenopausal women. Now, when we do the T-scores in our machine, so you can be using the GE machine or the Hologic machine, you should know that the reference standard is the T-score, that is, which we use to calculate here, is calculated from the female white database, the Enhanced 3 database, which uses females aged 20 to 29 years. And this was a study which was conducted from 1988 to 1994. So this was based on data of about 14,000 individuals. So this should be kept in mind when you're interpreting the T-score. So when you're measuring BMD of somebody in India, you're actually comparing them to this population, and that's how you're getting your T-score. Now, does the reference database have an impact on the diagnosis of osteoporosis? Now, this was a study published by Sahana ma'am, and this looked at hip fracture patients. So there were 316 hip fracture patients in this study, and 73 of these patients, that is almost 23%, were defined as osteoporosis according to the Hologic database, that is the Enhanced 3 database. They were reclassified as osteopenia if you use the ICMR database, which is specific to India. So we have another study, again, Kripa ma'am published this. So this looked at the database that was available from North India. So the North Indian database was used to see how it makes an impact if you use the Enhanced versus the North Indian database. So when you use the North Indian database, about 88% of patients were correctly classified as osteoporosis compared to 73% when you use the Enhanced database, and there was a good correlation between both of these databases. So the usage of the reference database is also very important. Now we have a lot of studies on this, but still, as of now, we are still using the Enhanced 3 database in our study. So T-score should not be used in pediatric DEXA reports. That's very important. The term osteopenia should not be used in pediatric DEXA reports. Osteoporosis should not be used unless there is a clinically significant fracture history, like I mentioned about. Low bone mineral mass or bone mineral density is the preferred term for pediatric DEXA reports when the BMC or the aerial BMDZ scores are less than or equal to -2 standard deviations. So the measurement sites, we know we do the dual femur and the lumbar spine as a routine, but when do you actually do the forearm BMD? So forearm BMD should be measured in certain circumstances. If the hip or spine BMD cannot be measured or interpreted, in cases of hyperparathyroidism, or if you have very obese patients, who are over the weight limit for the DEXA table, you can go for the forearm BMD as well. And when you talk about sites for the pediatric bone mineral density, the two sites that are preferred are total body less head and the AP spine. So coming to positioning, so when you're looking at your bone mineral density report for the lumbar spine, what actually you should be looking, there are 3 or 4 points that you should make sure are correct before going on to interpreting them. So the 12th ribs should be visible, as you can see. So yellow lines are drawn by the DEXA software, and these demarcate the region of interest, and these lines should clearly outline the vertebral bodies. Of course, the spine should be straight and the spinous processes should be well aligned with each other to ensure symmetry of the spine. And analysis should include L1 to N floor. Unless you have certain circumstances, I'll show you the cases for that, where you actually exclude one of the vertebra, 1 or 2 of the vertebra. And iliac crest should be symmetric and between L4 and L5. So if you have this in your report, that means that the positioning at the spine is right. So here you can see the correct positioning on the left and the incorrect positioning on the right. So what happens when there is a rotated film? So this actually falsely decreases the bone mineral density as much as a 50 to 60% rotation can actually decrease the bone mineral density. So that's how you interpret it. When you look at the positioning at the femur, so the neck box region of interest should be placed in the center of the femoral neck. In the hologic machines, it's slightly different. For the lunar machines, they say at the thinnest point, you should place the ROI. So again, yellow lines are drawn by the DEXA software, and these demarcate the region of interest, and these should clearly outline the hip. Circular ROI should well outline the femoral head. Pubic bone should be visible, as you can see in the picture. And if the femur is properly rotated, the lesser trochanter should be seen minimally. So if you see a lot of it, that is also wrong. Or, if you don't see it, that is also a slightly wrong positioning. If you just see the lesser trochanter, then you see that the rotation is actually right. So again, examples of correct positioning. Here you can just see the lesser trochanter. Here you can't see it at all. Incorrect positioning at the femur. So let's look at a few case-based examples and how you actually interpret it. So this is case 1. A 69-year-old woman undergoes dual energy X-ray absorptiometry as a part of a routine annual evaluation. She attained menopause at 52 years and she has no history of fractures. Now this is her bone mineral density report you can see here. So what you can notice here is the L2 vertebrae, the T-score is -1.3. So this is very different from the L1. So the standard deviation of more than 1 from L1 here. So you should actually be suspecting what's going on here. And when you do the X-ray here, you can actually see that there is aortic sclerosis. So when you interpret the BMD here, you should exclude L2 from your analysis. So the ISCD guidelines say that L1 to L4 should be used, but if there are vertebra with certain artifacts, you can exclude one vertebra and consider the other 3. If there are 2, then you exclude 2 vertebra and consider the other 2. So artifacts at lumbar spine could be due to osteoarthritis, fracture, end plate sclerosis, calcified aorta, radio-opaque materials can also affect the BMD. So magnitude of increase due to osteophytes, it can vary from 9.5 to as much as 13.9%, and there are various causes of overestimation of BMD or even underestimation of BMD in cases like lytic metastasis or recent radionuclide examinations, which can affect your interpretation. So another case example, so this is another lady who had a routine bone mineral density examination, and you can see here the L1 to L4 is the T-score is actually read as -0.5. 5. But when you look at L1, L2, L3 and L4, you see that it's minus 2.1, minus 1.7, 1.1 and 0.1 here. So here there is increased density in the radiography in L3 and L4, which you can also corroborate in the picture there. So there is a large difference in BMD between the L1 and L2 and also the L3 and L4. The T-score variation is more than 1 standard deviation. So you exclude L3 and L4 from the final interpretation here, and you take the final T-score from L1 and L2, so that is minus 2.1 and minus 1.7, and the T-score here, final T-score here will be minus 1.9. So this is how you interpret at the spine. And of course, we know this. So many of my friends just call me and tell me that this patient has had multiple fractures. I have a BMD report in front of me. The T-score is 0.2, 1.5 or minus 1.1, and it's very essential to ask them to send the pictures, because many of the times there are prostheses and you are getting a falsely high BMD. Now going on to case 4, this is a 15-year, 4-month-old child with thalassemia major on iron chelation. She is referred with short stature and delayed puberty. The height STS is minus 2.5, weight STS is minus 2.3, and when you look at the BMD Z score, it is minus 3.1 here, and the total body less head BMD Z score is minus 3. So what actually you should be doing here is correcting this with the bone mineral BMAD. So here you can use the Carter formula to calculate the BMAD, and when you do the BMAD here, you can see that it is minus 0.8. The Z score with BMAD is minus 0.8. So this patient did not have any back pain, no reported fractures. So the interpretation is actually normal bone density for stature. So you have gone from a Z score of minus 3.1, and when you correct it for the stature, you go to a BMAD Z score of minus 0.8, which is actually normal density for stature. So the Carter formula is available online. You can actually calculate BMAD using the Carter formula. Coming on to case 5. Now this is a 71-year-old female with history of type 2 diabetes since 10 years, and she has had a history of fragility fracture. So here you can see that both the lumbar spine and the femur BMD is suggestive of osteopenia here. But when you do the vertebral fracture analysis, you can see that there is a severe compression at T12 vertebra, and also the TBS in this lady is 1.176. So this is suggestive of degraded trabecular bone. So this is very important in diabetes, because in diabetes, the BMD can be falsely high or normal, but there is an increase in the prevalence of fractures. So this is the ICMR INDIAB study, which studied about 54,000 patients. And when you look at the self-reported fractures, they were the highest in diabetes and also high in pre-diabetes as compared to subjects without diabetes. And when you look at the multivariate logistic regression analysis for the risk of fractures in diabetes, diabetes itself, is a major risk factors. Even like, comparing them to age or alcohol consumption or BMI, diabetes by itself is a major risk factor for fractures. So we know the BMD paradox in type 2 diabetes, so you can have a high bone mass or even a normal bone mass, but the patient is at a higher risk for fractures. And at a particular T-score, the patient with diabetes has a higher risk of fractures as compared to somebody without diabetes. So if you have two patients, one with diabetes and one without diabetes, both having a T-score of minus 1.5, the patient with diabetes is at a higher risk of fractures, as you can see here from this graph. So fracture risk in diabetes remains associated with aerial BMD, but is nearly 50% higher at each T-score than in postmenopausal osteoporosis. But as we said, they can have a normal BMD or even increased BMD in the early stages of disease. What about type 1 diabetes? Now this is something that we published recently. So BMD was not different in patients with type 1 diabetes, but TBS was significantly lower. So Kripa ma'am is going to talk about TBS and VFA, but these are modalities which can help us, diagnose osteoporosis in patients with type 2 diabetes where BMD may not be contributory. And it's very important to remember the T-score cutoffs is slightly different in diabetes. The ADA recommends a T-score cutoff of -2 to initiate treatment, as opposed to the T-score of -2.5 that we take in patients with non-diabetes. So if we have time, we can quickly go through another two cases. So here we have 70-year-old female. There is no history of fracture here. You can see the L1 to L4, the T-score is minus 3.7. So, but as you can see, the labeling is improper. So the L5 vertebra is actually labeled as L4. So this with correct labeling, this is the correct labeling, L1 to L4. That is also very important to look at the labeling of the lumbar vertebra. Now you have the L1 vertebra. If you look at the T-score, it's again, the standard deviation is more than 1 when compared to L2, and that you exclude from the final analysis. So L2 to L4 T-score would be minus 3.4. So the last case, so this is a 72-year-old man, again, right femoral neck fracture. You can see that on the BMD picture as well. So here you have a falsely high right BMD. Here the T-score is minus 1.4 as compared to minus 4.2 on the left. So you exclude the right from the analysis and take the left femur BMD for diagnosis. So that brings me to the end of my presentation. Happy to invite all of you to ISBMR 2025, which will be held on the 25th and 26th of October in Mysore. Thank you.
Thank you, Chairpersons, and good afternoon to everybody. It's my privilege to stand on home ground and speak to you a little more about DEXA, because this is where I learned the basics of clinical densitometry. So let's look at some of the other measures, and this will be the outline of my talk. So I don't need to tell you that osteoporosis is a prevalent problem. These are a few facts and figures that I have put up. The prevalence ranges anywhere from 30 to 60% across the country, and we don't have much data on hip fractures, but what is available has shown that the incidence can range anywhere between 105 to 160 per 100,000 individuals. The gold standard we heard is DEXA scan. There are two energies of X-rays. These are attenuated to different extents by different compartments of the body, and the difference in attenuation is what helps us to differentiate between bone and muscle and fat. It's compared to a standard. T-scores and Z-scores were already covered by Dr. Lakshmi, and this is how a normal DEXA report would look at. As Dr. Nitin mentioned, it's important to look at all these boxes, the center, the demographics. Besides the BMD, have a look at whether the spine has been positioned correctly, the hip has been positioned correctly, what is the make of the machine, and also have a look at both the T and Z scores, particularly in elderly individuals, because if there is a gross discrepancy, like as you can see, this is a 50-year-old lady with a severe osteoporosis as defined by T scores. However, her Z scores are also low, which means she's faltering compared to her peers. Look for secondary causes, and this lady had a multiple myeloma. So now let's look at some of the other measures. So trabecular bone score, from the name it is evident that we look at the trabecular bone, and it's the lumbar spine that is rich in trabecular bone. So these are two images that I have shown. I think you will agree with me that in this bone, the trabeculae are well disposed and it's packed with trabeculae. The BMD is good and the trabecular bone score is normal or good. Whereas in this bone, you can see that the bone is porous, the trabeculae are a little more spaced apart. The bone mineral content per unit area, which is BMD, is good, but the trabecular bone score is low. So the quality of the bone is not good, as is wrongly conveyed by the bone mineral density, and this is where the importance of TBS lies. So these were the original cutoffs that were proposed. It is accurate between BMI, in a BMI range between 15 to 37, but based on newer studies and more evidence, the newer cutoffs are more than 1.31, which is normal, less than 1.23 is degraded, and anything between this is considered as partially degraded bone. So now there is a position statement itself on the utility and the use of trabecular bone score, based on the premise that TBS is predictive of fragility fractures irrespective of a BMD, and it does add value when you use the FRAX algorithm. When FRAX is not available, you can adjust BMD for TBS, and I will come to that. And one of the greatest uses of TBS lies when the intervention threshold on FRAX is on the fence and you don't know whether to treat or not. When you incorporate the TBS, it might cross intervention thresholds and you can make decisions on treatment. The other uses would be to monitor therapy, whether the patient is on antiresorptives like zoledronate or denosumab or on anabolic therapy. Again, in secondary osteoporosis, it does have value, and I'll come to that. Type 2 diabetes, CKD, glucocorticoids, various rheumatological diseases, and it's usually not affected by spinal changes like osteophytes and syndesmophytes. So this is the TBS adjusted BMD T-score. This was published last year. It has a complicated formula which is available online. So for a 59-year-old lady, if the lumbar spine T-score is minus 1.2 and the TBS is low and you don't know what to do, you can adjust the TBS, you can adjust the lumbar spine T-score for the TBS based on this formula and arrive at new T-score thresholds based on which you can make treatment decisions. So around 30% of those who are not osteoporotic will fracture, and that is why it is recommended to use TBS in the elderly, like women more than 65, men more than 70. If they are below these age cutoffs, then if they have another cause for low bone mass, like a low body weight or glucocorticoid use, or if they have a fragility fracture, any other condition that is associated with secondary osteoporosis, it is recommended to do a TBS, or if they are planned for therapy. This study was published from our center a few years back, wherein we looked at 197 women at baseline. They received zoledronate. They were followed up over a period of 2 years. 132 women completed the follow-up. We found that there was a significant increment in BMD and the TBS remained stable. Or in other words, it did not deteriorate. So these are situations where you can use trabecular bone score to monitor therapy. A more recent study that was done by one of our postgraduates, we looked at 3 groups of women who were non-obese, obese and morbidly obese. Each had 80 to 85 individuals. What we found is that the BMD at the lumbar spine was not significantly different between the groups, but the trabecular bone score in the morbidly obese showed a sharp dip, and this was significant. So obesity does not always translate into good bones. It may have some protection against hip fracture, but the trabecular bone score at the lumbar spine in morbidly obese might be low. Another aspect not very well known is the hip structural analysis. The background for this is that BMD is only a surrogate marker which looks at the inorganic content of the bone, the collagen, the bone matrix proteins, which also contribute to bone strength, are not accounted for. Again, bone strength is not dependent only on BMD, it also depends on the force, the rate, magnitude and direction of application and the geometric aspects of the proximal hip. And there are many forces that can act on the bone. These can be compressive, distraction or tension. The bone can be bent, it can be sheared, it can undergo torsion. And this is analogous to big buildings where architects and engineers, to study how much load the building can take, they would make use of computer simulated models. And proximal hip geometry is studied in a similar way by looking at densitometric images of the proximal hip. And the areas of interest would be the narrow neck, which is the narrowest portion of the neck, the intertrochanteric region and the femoral shaft, which is 2 centimeters below the lesser trochanter. Why these 3 regions? Because these are the weakest areas of the bone that is most prone to fracture. These are the various indices that are looked at. In the interest of time, I will just touch upon buckling ratio, which is only a ratio. So this is a diagrammatic representation of the cross section of the bone. This D0 is the subperiosteal width and T is the cortical thickness. Buckling ratio is nothing but D0 by T, and it is a measure of cortical stability. So what happens with age is that the cortex thins out, which means the buckling ratio increases, and it does have some utility in fracture prediction. A buckling ratio that is more than 10 at the narrow neck has a high risk of fracture. So just to illustrate what happens with aging, if you will just focus on this first line and the last column, this is the buckling ratio of a 20-year-old, 6.8, 8.3 in the 30s, around 7.68 in the 40s, 10 in 59, 72, 13.6 in a lady who is 84, 17 in a person who is 93, and this individual had a buckling ratio of 20. He was not above 100 years old, but this person had diabetes. So that is why these other adjuncts are useful. This person was a 60-year-old with type 2 diabetes. So to illustrate my point further, this is a 59-year-old lady who was known to have uncontrolled diabetes. She was referred to us from ortho after surgery for a right hip fracture. So when we looked at her BMD, at the lumbar spine it was minus 1.2, and at the neck of the left femur it was minus 2.2, both being BMDs in the non-osteoporotic range. And as Dr. Lakshmi mentioned, this is one of the pitfalls of BMD assessment in diabetes. Paradoxically, it appears to be good. When we looked at her TBS, it was 1.158, which is indicative of degraded microarchitecture, and her buckling ratio at the narrow neck was 14. So sometimes it might be useful to look at other adjuncts when we want to study bone fragility in its totality. So we have looked at various densitometric indices following teriparatide therapy. We have looked at men with cryptogenic cirrhosis. We have looked at women with hip fracture. We have looked at the cohort of diabetes mellitus, a few cases of osteomalacia, and we have found that these other adjuncts, be it TBS or the hip structural analysis, does show robust changes or differences when compared to healthy controls. Let me just touch upon bone strain index. This is again a novel tool which requires additional software on the DEXA. It can be used along with BMD, and it points to the level of strain inside the vertebral body. Limited studies are available, mostly from the Pioneer group in Italy, where they have shown that it does have utility in predicting the first fragility fracture and the risk of recurrent fractures. So in this lady with multiple fractures who had osteoporosis based on BMD, this is her vertebral BFA, which I will come to later. She had fractures. Her TBS was 1.09, which was low, and her bone strain index was 2.58. So anything that is 1.68 and less is considered normal. Anything that is 2.4 and more indicates a reduced resistance to fractures or a high bone strain index. So this is one study that we looked at recently, where we studied women and their salt intake. The average salt consumption was high at 7.2. Based on this, we divided them into two categories of low and high salt intake, and we found that in the high salt category, the BMDs were low, the TBS was low, and the bone strain index was high. So another study that we looked at recently was in renal transplant recipients at baseline before transplant, and we followed them up. The 1-year follow-up study was published recently. Further, we have also looked at what happens to them at the end of 4 years. We have data on that. What we found interestingly is that following transplant, the BMD at the hip and the forearm improves, probably because the secondary hyperparathyroidism improves. The lumbar spine BMD just about stabilizes. However, the trabecular bone score and the bone strain index show evidence of deterioration. So this again goes to say that BMD as a standalone tool may not suffice. You might have to look at other adjuncts as well. This is a soon to be published article which was accepted by the IJM recently, wherein we have highlighted the utility of HSA and BSI in fragility fractures in the absence of osteoporosis or in conditions that can have a paradoxically high BMD, degenerative spine conditions. We don't have ethnicity specific cutoffs for these, and this is something that we are working on. Again, to highlight the other uses of DEXA, let me mention a case of a 67-year-old lady with rheumatoid arthritis on long-term steroids, DMARDs, postmenopausal, on bisphosphonates for a long time, and she was on follow-up with rheumatology elsewhere. In 2009, she presented with this subtrochanteric fracture of the right side, for which she underwent an IM nailing. Alendronate was stopped. We noticed that the cortices of the other side were thick as well. Although bisphosphonates were rightly stopped, she came back 4 years later with a fracture of the opposite side. So she had an atypical femoral fracture for which she underwent intramedullary nailing. Again, this is a lady with multiple myeloma who was on long-term bisphosphonates. She had presented with a left-sided groin pain, and her X-ray had shown this characteristic beaked appearance of the lateral cortex. This was fixed. During this time, her femur on the right side had been normal, but she came back a few years later with right-sided thigh pain, and she was found to have again this new beaking which had not been there previously. So just to highlight that even when you stop bisphosphonates, atypical fractures can occur much later as well, and therefore long-term follow-up is warranted. Why do I mention this here is because the assessment or screening for an atypical femoral fracture can be done on a DEXA scanner. This is how it would look like normally. So the imaging is called the full femur length imaging, or the FFL. This is nothing but a densitometric image of the full femur, and it makes use of a single energy X-ray beam. This lady, 73 years old, had presented with right-sided groin pain. When we did her FFL, she was found to have a beaked appearance of the right medial cortex of her femur. So now it is recommended and endorsed by the International Society for Clinical Densitometry that when you have patients on long-term anti-resorptives for a cumulative period of 3 years and more, be it bisphosphonates or denosumab, do an FFL screening on the DEXA scan and look for a horizontal translucency, and that is called the dreaded black line, and that should be addressed. Just to touch upon VFA, what is VFA? To illustrate that, this lady who was 73 years old had presented with low backache. Her DEXA scan did not show osteoporosis. However, her spine X-ray had shown the presence of multiple fractures. This would have been missed if I had only gone ahead and done a BMD. So VFA is again a densitometric image of the lateral spine. This is the VFA of the same patient which showed multiple fractures. So what is VFA? The DEXA scan will image the spine. You can objectively assess the number of vertebral fractures, the severity of fractures, and the type of fracture, whether wedge or biconcave or crush. The advantages are that it can be performed simultaneous with that of a BMD assessment with much less radiation exposure as compared to conventional X-rays. This was a young lady, actually 40-year-old premenopausal lady who had presented with a loss of height and low backache. As you can see, she had multiple vertebral fractures, and we started her on anabolic treatment with teriparatide with sequential denosumab as well. And to monitor her, we are doing serial VFAs to look for whether she has worsening of her existing vertebral fractures or whether she has additional vertebral fractures. So that is another advantage of the VFA. The indications would be women more than 70 or men more than 80 years, especially if they historically have a height loss that is more than 4 centimeters, if they have self-reported but undocumented vertebral fractures, or if they are on long-term glucocorticoid therapy. So to summarize, a normal DEXA report has a wealth of information. Remember that beyond BMD, there are several other applications of DEXA that might be explored. TBS is an independent predictor of fracture. Proximal hip geometry can be archived from densitometric images of the hip. BSI is a novel index, and more Indian studies might be needed in this regard. Thank you.